Good evening, colleagues, and welcome to tonight's webinar. It's the first in a four-part series, which will be taking place in the month of October, which I'm sure, as you all are familiar, is now Oral Health Month. And how it's going to work, it's basically the same day, same slot, weekly. And each week it's going to be delivered by a registrar who are busy specializing in the field of oral medicine and periodontology at our four institutions, namely Sefako Makgatho Health University, the University of Pretoria, the University of the Witwatersrand, and the University of the Western Cape. And this webinar series is hosted by SASPIO, the South African Society for Periodontology, Implantology and Oral Medicine, of which I am the treasurer in collaboration with Sandra. So I'm hoping that this first webinar will entice you to attend the next three. All four topics for this month are actually oral medicine, which I'm very happy about, because I tend to find that oral implantology is taking over, and this is a very interesting field, which, you know, we sometimes tend to forget. Before I introduce tonight's speakers, I just wanted to get some announcements out the way. So with regards to comments and questions, please type those in the chat as opposed to raising your hand, and we will attend to those at the Q&A session, but keep those questions coming during the talk. That's not a problem. With regards to CPD certificates, they will be loaded onto the SADA platform, and you can access these certificates under your profile, but it takes about 10 days, I believe. If you're not a SADA member, you will have to create a profile for yourself to access the CPD certificate, and if you care for the whole duration, the 1 hour duration, that will earn you 1 CPD point. We are streaming live on YouTube as well. So if you're struggling with this platform, you can move across. But unfortunately, if you're accessing it through YouTube, you will not earn your points. So without further ado, let me introduce our first speaker tonight, Dr. Golele. So just a short history. She was born and raised in Pretoria, and she completed her undergraduate degree at Sefako Makgatho Health University in 2016. She thereafter graduated with her master's in dental science, particularly in the field of oral medicine, from the University of the Witwatersrand, and she is currently a registrar at Sefako Makgatho Health University, as I mentioned, in the field of oral medicine and periodontology. She has also completed a laser therapy course that focused on the treatment of periodontal disease using a variety of diode lasers. She's very passionate about surgery, and she plays the violin in her spare time. So Dr. Golele, welcome. Thank you for giving us your time and speaking about this topic, which is also something I enjoy very much. So I'm looking very forward to it. The platform is yours.
Thank you, Dr. Koutras, for the warm introduction, and thank you everyone for joining this evening. I'd like to thank SASPIO for the opportunity, as well as Sandra for the opportunity to present this evening. Just give me a minute as I upload my presentation. Is everything okay, Dr. Koutras?
You're good to go.
Thank you. So tonight I will be presenting on a very broad topic, but I'm going to zone it in as much as I can, titled Pemphigus Vulgaris, an Autoimmune Battle. So Pemphigus Vulgaris is a rare autoimmune, potentially life-threatening mucocutaneous disease. Now, Pemphigus vulgaris is the main variant that affects the oral cavity, and infection is the most common cause of death, particularly pneumonia and sepsis. It's quite important for us to understand that under the group of pemphigus, we have different variants, some that are rare, some that are or have a neoplastic variant or characteristic. And it's important for us to bear in mind the variant that is your paraneoplastic pemphigus, and Although this presentation won't necessarily be focusing on paraneoplastic pemphigus, I'd like to give a brief overview so that one can understand the diversity as well as the severity of the conditions that fall under the group of pemphigus. And with your PNP, or your paraneoplastic pemphigus, it's usually associated with your lymphoproliferative diseases, and up to 84% of your PNP cases are caused by a hematologic neoplasm or disorders. Now, with your PNP, it's always characterized by an association with a neoplasm, and this can include neoplasms of the stomach, it can include neoplasms of the colon, as well as the lungs. Now, clinical features are extremely polymorphous, and your PNP lesions can be detected not only on the skin, but also on different areas of the mucosa. Now, the presence or the severity of this is, or the significance rather, of paraneoplastic pemphigus, as I mentioned, is the fact that the neoplasm is detected, and it's always before the onset of your PNP. So with the group of immune-mediated conditions, we have a subset known as your autoimmune conditions. So with your autoimmune conditions, one needs to understand that these are conditions where you have self-tolerance that is lost. And the meaning of that is that with healthy, normal human beings, we have antigens that are within our bodies, and the body is able to self-regulate against any sources or any antigen or foreign particles that are presented within the body. However, when self-tolerance is lost, it causes an autoimmune dysregulation, and this translates or manifests as any sort of autoimmune disease. This is an enigma in the sense that with your etiology, your pathogenesis, and triggering factors of pemphigus, they are known to be enigmas, and so this is why this discussion needs to be had. So there are some triggering factors rather that have been identified as culprits, including certain drugs. And these drugs are your thiols, your phenols, as well as your non-thiols and your non-phenols. We also have your nutrients and micronutrients that are implicated as triggering factors in the manifestation of pemphigus group or pemphigus groups or diseases. Then you have subsets of conditions such as pregnancy, as well as states of stress that can be triggering factors in pemphigus disorders. Now, for us to get a full understanding of what Pemphigus vulgaris is, we need to take a look at the normal epithelium and what it's made of. So epithelium in the oral cavity is made up of stratified squamous epithelium. And your stratified squamous epithelium is made up of keratinocytes. Now, the different layers in the oral cavity, or rather the oral cavity, is covered by different types of epithelium. We have specialized epithelium, keratinized epithelium, as well as non-keratinized epithelium. Now, in the first image on the left, we have what is known as your your orthokeratinized rather epithelium. And this is constituted by the absence of this is characterized rather by the absence of nuclei within that layer. And you can clearly see depicted in your keratinized layer that there is no nuclei present in your stratum corneum. I also just want to take you through the beautiful H&E staining of these different slides. As you can see, the first layer is your stratum corneum, also known as your keratinized layer. Then we have your stratum granulosum, your stratum spinosum, otherwise known as your prickle cell layer. And then we have what is known as your basal layer, and that is beautifully stained with your hyperchromatic nucleus that's darkly stained purple. And in the middle slide, what we have here is a parakeratinized oral epithelium. Why is it parakeratinized? Is because we have the presence of stained nuclei within that keratinized layer. You can clearly see that darkened stained hyperchromatic nuclei that's present. And the last slide illustrates a non-keratinized oral epithelium. And as I mentioned, because the oral cavity is covered by a variety of different types and different maturation types of your epithelium, it's good for us to have a basic understanding of how the oral cavity looks in normal conditions. Now, if we zone into what that looks like on a high magnified scale, we have these keratinocytes that we have two cells here, two keratinocytes that are attached by adhesion molecules. And the significance of this is that when we're dealing with Pemphigus vulgaris, it targets specific intraepithelial adhesion proteins or molecules, which is what this image illustrates. So we have two keratinocytes that are joined intraepithelially, meaning connecting the two cells by desmoglein 1 and desmoglein 3. And this is significant in terms of the pathogenesis of Pemphigus vulgaris. Now, I want to point out here that in the slide, we have a zoned in view of the basement membrane as well. And its significance is that we also have a group of pemphigoid type of diseases. And there we have what's called a subepithelial splitting or subepithelial cleft that's formed between the attachment of your hemidesmosomes of your keratinocyte and the basement membrane itself, as opposed to Pemphigus vulgaris, where we have what's known as your intracellular blistering or intracellular acanthosis, or the splitting of the cells in between. So Pemphigus vulgaris is characterized, as I mentioned, by underlying intraepithelial blister formation that's caused specifically by your immunoglobulin G, your autoantibodies that work against those desmosomal adhesion proteins, and mainly your desmoglein 1 and 3. Now, the severity of your Pemphigus vulgaris refers to its progressive course, which is often accompanied by a high metabolic state with the loss of your body fluids, proteins, as well as secondary bacterial and viral infections that may essentially lead to septicemia. So with your IgG antibodies targeting your specific desmoglein 1 and 3, there also seems to be a genetic association with your MHC, also known as your human leukocyte alleles, class 2 genes that are affected. And so the most reported PV or Pemphigus vulgaris associated HLE class 2 alleles are your DQB1 as well as your DRB1. And these are expressed on your antigen presenting cells. So most patients with Pemphigus vulgaris with only desmoglein 3 autoantibodies develop mucosal dominant phenotypes, as opposed to patients that have both your desmoglein 1 and your desmoglein 3 reactivity that display what is known as your mucocutaneous lesions. In essence, what we're saying is that you have manifestation of lesions on both the skin as well as mucosal surfaces. So we also have what's known as your desmoglein compensation theory. And basically what this states is that in the skin, your desmoglein 3 is only expressed in the basal layer, while your desmoglein 1 is expressed throughout the whole epithelium, and therefore can compensate for the loss of your desmoglein 3, as opposed to the oral mucosa, the mucosa, where your desmoglein 3 is expressed throughout the whole epithelium, and your desmoglein 1 only expressed highly in your superficial layers and significantly low in your basal layers. And therefore, the loss of your desmoglein 3 cannot adequately compensate for desmoglein 1. And this is why at times you can have oral manifestations without skin manifestations. So I'd like to take you through a case that we are currently managing in the Department of Oral Medicine and Periodontology. And before I get started with this, just a brief overview. This is a very intensive case and was treated, or is being managed rather, as a multidisciplinary case. So as I introduce this patient, I'd like you to keep that in mind. This is a 37-year-old female that resides in Soshanguve, Pretoria. She is married with 3 children. When she presented, her main complaint was that I have sores in my mouth. And with the history of the main complaint, she reported that her oral lesions appeared first in 2019 and then were followed by lesions on the trunk in December of the same year. So in 2019, before she presented to us, she was hospitalized for extensive blistering on the entire body from the head to the toes. She was admitted at the burns unit at the Dr. George Mukhari Hospital with initial presenting pus-filled blisters that later became clear fluid blisters. And then we had the oral lesions that presented. And the patient was then after released from the burns unit and referred to dermatology for further care. Now in 2020, dermatology was still managing the patient and was placed on prednisone 30 milligrams, methotrexate 10 milligrams. She was given a vitamin B supplement, folate supplement, as well as a chlorhexidine 0.2 mouthwash to rinse with. Now, I'd like to state here that the patient was then referred to oral medicine, where she was managed by a dentist. And then the patient was then referred to me in 2021, where we started managing her. Now, before we got to see her, dermatology did take biopsies of the back of the patient. I'd like to show you the extraoral examination of this patient. She presented with bilateral hyperpigmentation of the skin that extended from the temporal area on both sides bilaterally and extended down to her neck area. She had areas that were affected of hyperpigmentation on her forehead as well. She also then presented with erosive lesions on her upper chest. If I can just orientate you, this was the patient's neck, so just below her neck, her upper chest. The patient presented with erosive lesions as well as healing lesions with a base, obviously, of that hyperpigmentation as a result of the healing of those lesions. Intraorally, the patient's initial presentation, she presented with bilateral, diffuse or generalized fibropurulent lesions with ulcerations as well. And besides her main complaint being the fact that she had sores in her mouth, I think the biggest thing that she mentioned, or the biggest outcome that she wanted, was a relief of pain, although this is not what she stated in her main complaint. So these lesions or erosive lesions extended to the floor of the mouth. Again, you can see here, we have a fibropurulent lesion with areas of ulceration. When the patient was referred to us 12 months later, I then took over the case. Now, these are the extraoral examinations of the patient to date. Now, I just want to backtrack so that you have an understanding of how the patient is now looking different. As I mentioned, in 2020, dermatology was managing the patient, and this has extended through to 2021. So the patient has still been placed on methotrexate. And what happened with this particular patient, I don't know if you have noticed, but the patient has gained a bit of weight. The patient was taken off of prednisone because she was developing cushingoid symptoms, which can be clearly seen with the weight gain around her shoulder area, her face area, and she also had purple lesions on her lower extremities that can be written off or described as stretch marks that were large and purple in presentation. So at this point in time, what had happened with this particular patient was that when she was referred to us, she had a biopsy taken, 2 biopsies taken intraorally on the buccal mucosa. So the patient had a lesion or lesions presenting on the upper labial mucosa, as well as the lower labial mucosa. Again, we can see that these are diffuse erythematous ulcerations that also extended to the hard palate and extended backwards to the soft palate. We also can see involvement of the lingual frenulum, as well as involvement of the buccal mucosa. These were the images of the patient's tongue, and as you can see, it looks quite painful. She presented with generalized ulcerations on the lateral borders of the tongue, as well as involvement of the tongue dorsum, which extended as well to the ventral surface of the tongue. You can also appreciate that the patient had hemorrhage on the lower lip when she presented to me. Now, how was this patient managed overall? So when the patient presented, she, as I mentioned, she had 2 biopsies taken. And when one wants to identify if we're dealing with an autoimmune condition, there are 2 types of tests that one needs to take. And what do we expect to see in those 2 tests? So we have your histology or histochemical staining, which is your H&E, as well as direct immunofluorescence. Now, immunofluorescence is a histological laboratory staining technique used for demonstrating the presence of autoantibodies that are bound to antigens or circulating body fluids. Now, when a biopsy is taken, there are usually 2 specimens that are required to get a definitive diagnosis. So we have a lesional tissue that's taken, as well as perilesional tissue that's taken. Your perilesional tissue illustrating the tissue that will be adjacent to, for example, a vesicle or a bullous that may be present, or adjacent to that, and then your lesional tissue, which would involve the bulla or the vesicle. And what we expect to see in this imaging is the H&E staining of the skin. So dermatology went ahead and took biopsies on the back of this patient to determine or to ascertain the definitive diagnosis. And I say that this is a complex case because dermatology had one thought in terms of the definitive that they had and a differing diagnosis that we had from oral medicine. So a lot of the time when you're dealing with immune-mediated conditions, specifically autoimmune conditions, you can have differential diagnosis or diagnoses that overlap. Hence, the need for specific direct immunofluorescence to be able to get a definitive diagnosis. And so what we have here is the histopathology of the skin. And what you can appreciate in these slides are low, medium, and high magnifications of the skin. And what we have here is we have on the left-hand side, the entirety of the specimen that they took on the back of the patient. And what you can appreciate, if you remember the imaging that I showed you of normal epithelium, we have keratin, a keratin layer, that's the topmost layer. And you can see that there's separation of the epithelium from the basal membrane or the basement membrane. What you can also appreciate is a connective tissue in that first imaging of the specimen in its entirety. When we move to the right-hand side, you can again appreciate the keratin that's on the skin, as well as that blister formation that has caused clefting between the basement membrane, as well as acantholysis of the cells or the keratinocytes within the spinous layer, specifically with Pemphigus vulgaris, that needs to be noted. You can also appreciate the areas that are stained more darkly in this last imaging, the right-hand picture. You can appreciate the darker stained cells, and these are your erythrocytes, which also are characteristic of hemorrhage or bleeding. So the histological report from dermatology came back with a diagnosis of subepithelial blistering, which caused a bit of confusion because in essence, when we're dealing with a Pemphigus vulgaris, we are thinking of a suprabasal splitting or suprabasal clefting, as opposed to a pemphigoid, which you'd find a subepithelial or subepidermal blistering formation. However, the immunofluorescence showed us that there was positivity for your autoantibodies or immunoglobulins IgG, which is significant in terms of us dealing with your pemphigus group, as well as you'll see through your complement 3 positivity, which is significant in Pemphigus vulgaris. So the question here is, are you confused yet? So the histopathology of the oral mucosa then took us to, again, a holistic imaging of the specimen that was taken on the buccal mucosa, both left and right buccal mucosa, lesional and perilesional tissue. Again, your H&E staining will be used for the lesional tissue, and your immunofluorescence will be used for your perilesional tissue, and that will give you a definitive diagnosis of whether or not you're dealing with a Pemphigus vulgaris or something else, because you have specific reagents that are used. And your IgG, again, your IgG and your C3 are the main components that stain or pick up that stain in the cells. And so you can appreciate here that we have your epithelial layer that is ulcerated, and you can see that there's discontinuation of that epithelial layer. And this represents an ulceration, which is typical of what we have seen in the images of our patient. You can also then appreciate that clefting from the epithelial layer and the basement membrane, that's illustrated by this high magnification on the right-hand side with that white gap that you can clearly see between the basement membrane and the epithelial cells. This is a high magnification of what I've just explained. You can appreciate more clearly here the basement membrane that is stained with that hyperchromatic nucleus, the dark purple nucleus, with the separation and the white gap, that is the clefting that's occurred. And clinically, this will be seen as the bullous or the vesicle, that translates in, this is how it translates histopathologically. So for us to get a holistic view of the patient's requirements, needs, and medical status, serological testing needs to be done. So this was done by dermatology before she was referred to us, and we had the mean corpuscular volume that was assessed. The red blood cell incidence provides information on the physical features of the red blood cells. So we have your MHCH as well as your MHC, which are your mean corpuscular hemoglobin. And these are calculated measurements of the amount of hemoglobin that's inside the cell, the red blood cell, as opposed to your MCHC, which is the concentration or the average concentration of your hemoglobin inside the red blood cell. What was also of note here was the increase in your eosinophils, generally found in allergic reactions that tend to be manifested in your type 1 hypersensitivity. However, in this case, I want you to note that when we're dealing with a Pemphigus vulgaris, we are dealing with a type 2 hypersensitivity reaction, as opposed to that can be differentiated obviously from a type 3 hypersensitivity reaction. Although these both constitute antibody complex formation, with your type 2 hypersensitivity, we have these cells that bind to the surface membrane of the antigen or the cell antigen, as opposed to your type 3 hypersensitivity, where the same complex is formed. However, we have this complex moving to different organs. Hence, you have autoimmune conditions such as your systemic lupus erythematosus. We also had an increase in the erythrocyte sedimentation rate. And again, this shows the inflammatory response that was present at the time of the serological testing. So according to Kringid, there are various types of treatment modalities that can be implemented in the management of Pemphigus vulgaris, or in essence, your autoimmune conditions. Now, we have first-line drugs, second-line drugs, as well as third-line drugs. And ideally, your baseline investigations need to be taken. And this includes, like I've just shown you now, serologically, your full blood count, as well as your urea and liver function test, which was missing in this particular patient at the time of testing. And so the ideal treatment that one would institute in a case like this is either the use of prednisolone at a dose of 0.5 to 1.5 milligrams per kilogram per day. And this is according to the European Dermatology Forum, as opposed to the British Association of Dermatology, where they advocate for your 1.0 milligrams per kilogram per day. So when you're dealing with patients that are presenting with such conditions, it's imperative that the patient is weighed so that the right medication can be instituted. So all these are your baseline readings. So your serological testing, the patient's bloods, the patient's weight as well, needs to be taken so that we can account for liver function tests, we can account for dysregulation in any of the white blood cells, red blood cell count, or anything that may develop as a result of the medication that has been instituted, or us understanding if there's anything abnormal before we institute a particular drug. And so when we do institute a first-line drug such as prednisone, if the control of the disease is achieved within 1 to 2 weeks, a higher prednisolone, or if it's not achieved, rather, a higher dose of prednisone or prednisolone can be given, and this can go up to 2 milligrams per kilogram. Now, progressive reduction in the oral corticosteroid treatment should be commenced as soon as the disease is controlled, meaning as soon as we have resolution of the lesions, we can start with what is called a step down or tapering down of the medication, usually at a 25% decrease bi-weekly. And so over a more extended period of time, you can taper it down to 20, then you can go to 10, and you can end up at a maintenance dose of 5 for a longer period of time. Now, if you have recurrence of 3 or more lesions, according to the European Dermatology Forum, you can institute corticosteroids that are above the regulated dose, which is, again, that 1.5 to 1 or 1.0 to 1.5 milligrams per kilogram per day. So you can exceed that if you have recurrence of 3 or more lesions at a time. Now, the importance of using systemic corticosteroids is that they are immunosuppressants, and you have you have an adverse effect that can occur with the result or as a result of using these medications. So systemic corticosteroids can be combined with an immunosuppressive agent or immune sparing agents when complications are anticipated or prolonged use is anticipated at high doses. So we want to obviously prevent complications such as hypertension, diabetes mellitus, as well as osteoporosis. Now, according to the British Association of Dermatology, the guidelines advocate for the use of azathioprine, as well as your MMF and rituximab as your first-line drugs. However, the real challenge here is to prevent relapse in the long term and to avoid adverse effects associated with the prolonged use of corticosteroids. And so when we have such instances, they advocate for the use of going back to your first line medication. Now, with your second line drugs, as well as your third line drugs, it is noted that they aren't necessarily as effective as prednisone compared with the rapid onset of prednisone. They aren't always used as monotherapies, but they are mostly used as steroid-sparing drugs. So these are steroid-sparing drugs that are used in conjunction with prednisone. Azathioprine specifically is has a medium onset of 4 to 6 weeks. And so the use of azathioprine as a monotherapy is not advocated with regards to recalcitrant oral lesions. So when we're dealing with adverse effects, as I mentioned, we are looking at a multi-system, multi-systems that can be affected as a result of the use of corticosteroids. And these are numerous, and there's a plethora of side effects that can occur due to the use of corticosteroids. And these systems that can be affected include your musculoskeletal systems, your cardiovascular systems. We have your metabolic systems that can be affected with the result of diabetes, as I mentioned. And then we have your ophthalmologic problems that can occur. And then what's important as well here to take into consideration is your HPA axis association. And this is your hypothalamus, adrenal, or pituitary adrenal axis. And the relevance of this is the fact that when you are using corticosteroids, we have what is known as cortisol, and cortisol is considered a stress hormone. For you to control that stress hormone, you can have an imbalance when you have the institution of your corticosteroids. And so in the case of our patient, we were worried, or dermatology more so was worried about the cushingoid effects that, or side effects that the patient was developing. And so the use of corticosteroid can result in Cushing's syndrome, which is associated with swelling and increased levels of cortisol. And now the function of corticosteroids, which I think is quite important to understand, and why we use specifically corticosteroids, is that they function through the interaction of your cytoplasm of the corticosteroid, and they also form a complex. This results in an upregulation of expression of your anti-inflammatory proteins, which is essentially what you want, and a downregulation of your expression of your pro-inflammatory proteins. Now, the unbound corticosteroid enters the cell and exerts its effects by binding to the cytoplasm of the cell, the cytoplasm of the corticosteroid receptor, and this leads to their translocation into the nucleus and the formation of a dimer that binds to the corticosteroid response elements. Now, approximately 10 to 100 genes in each cell are regulated directly by corticosteroids. And so these corticosteroid receptors inhibit the transcription factors that have a dominant role in the inflammatory response, as well as their co-effector molecules. So it's important for us to consider when we are administering or choosing a treatment choice or a treatment plan or management for a patient such as this, to consider the side effects that can occur due to the medication that we are instituting, as well as, again, importantly, taking those baseline readings before a treatment is instituted. So the 1-week follow-up of this patient, which is actually quite recent, as the patient has had ongoing management from dermatology, when she presented to us, again, she presented with those recalcitrant oral lesions or non-healing oral lesions with that fibropurulent membrane. So this is how the patient presented initially and 1 week after. So how this patient was managed is that we put her back on prednisone, 65 milligrams of prednisone, and in conjunction with the dermatologist, we inquired on whether or not we needed to remove her or wean her off, rather, that azathioprine. And the dermatologist said no. So the patient is currently on prednisone as well as azathioprine. Again, that azathioprine she's been on for 3 weeks. And because it has a kick-in time of between 4 to 6 weeks, the prednisone, because of the rapid onset, resulted in a beautiful state that the patient is in now. Now, we don't have complete resolution. However, we do have improvement, much improvement. I'm happy to report that the patient is quite content, and she reports to be able to eat prawns, which are her favorite meal. And this makes us happy as practitioners when we see results such as this. Now, at this point, we did manage to send the patient for bloods so that we could check her liver function before this was instituted. So this is how she presented before and a week later. Again, that rapid onset of prednisone and the mode of action of prednisone resulted in a rapid resolution of some of these lesions. Now, she doesn't have resolution of all the lesions. She's currently remaining or struggling with that recalcitrant ulcerations on the tongue. However, these are much better than what they were initially. You can clearly see here that she still has ulcerations on the lateral border of the tongue, as well as the floor of the mouth, involving that lingual frenum, extending also to the tongue dorsum. However, like I said, the patient is able to eat quite well. So in conclusion, although there is no clear etiology that has been established for these diseases, the rare group of diseases can be induced or exacerbated by both genetic as well as exogenous factors. Now, appropriate referral is important in cases such as these, as well as ascertaining definitive diagnosis so that appropriate management can be given. Now, the aim is to reach complete remission and health for these patients and reduce the morbidity as well as possible fatality of patients. Now, finding the risk factors is necessary, as well as finding a balance in terms of the management of these patients. Now, although an effort has been made to introduce a common definition and endpoint for the management of Pemphigus vulgaris treatment, they are different. There isn't an international consensus that has been reached in terms of how PV should be treated. And so in our department, we have had a series of cases where we have seen a lot of autoimmune vesicular bullous disorders. And even in us managing these patients, we are trying to come up with a protocol that best suits our patients. And this unfortunately goes with a trial and error patient-specific basis. And so when you're treating individuals, although we have cases where patients present with the same condition, the management won't necessarily be the same depending on the baseline readings, again, of the patient's mental health, the patient's physical and medical health. And so sometimes you have individuals that respond well to prednisone and some that don't, such as this case. So the patient that we're managing now is under quite extensive surveillance or monitoring, because we are concerned about that the cushingoid symptoms that she has presented with. She won't be on prednisone 65 milligrams for long. At the moment, she is currently in her second week of 65 milligrams of prednisone, along with the azathioprine, which she has been taking to date for 3 weeks. And like I said, I'm happy to report that the patient is gaining resolution of some of those lesions with the aim of complete resolution. And once we reach complete resolution of the oral lesions, we will start to taper down that prednisone or the medication so that we can keep her at a maintenance dose as low as possible for a longer period of time that will result in no new eruptions occurring in this patient. So I hope that this was informative. Again, the aim is to reach complete remission of these, or to reach complete remission and health for these patients, and to decrease morbidity of the patients. And so the battle continues as we strive to conquer. Thank you very much for your attention this evening.
Thank you very much, Dr. Golele, I think on behalf of all of us, for your very elaborate presentation, and just your emphasis also on the multidisciplinary nature of treating cases like these, and the fact that over 65% of patients with Pemphigus vulgaris will have oral manifestations, and we might be the first practitioners that they visit with the complaint. So we are at the front line of treating them and knowing how to treat them, of course. So that's it. I don't have any questions from my side, perhaps just a statement with regards to statistics. They speak about 16 cases per year worldwide. How many patients are you seeing in the clinic? From what I can recall, we've seen at least about 3 to 4 just in this year.
Yes. So I think at the moment we are currently managing 2 to 3 PV cases and 1 MMP, so mucous membrane pemphigoid case that we are managing. And that outside of that, we also have the immune-mediated conditions that we have been seeing as well, erythema multiforme, that I think there was one specific case that we had where we thought that it was your SJS or your TNN. And so, like I said earlier, a lot of these cases can be differential diagnosis for each other. So it's very important to get a definitive diagnosis so they can be managed effectively. And with the cases that we have, like I said, it is a trial and error until we get that fine balance to manage these patients appropriately and get them into a remission state. I must say, though, it seems like we've hit a bit of a dry spell with these cases, which is a good thing. We're not seeing as many as we were initially. But yeah, we have quite a few of these in the department that we're currently managing.
Okay, so let's have a look at the chats to see if there's any questions, and I'll direct them your way. Okay, so some compliments, Dr. Golele, just as a starter. Excellent presentation. I'm going to start off with the first question. When would you suggest the next hematological tests for this patient? We've taken the baseline.
So hematological or serological testing should be done every 6 months. But in a case like this, because we have placed her on prednisone and she is not reacting as well as we'd like, we would do these every 3 months to get a record and to get accurate readings of liver function as well as FBCs. So every 3 months in this case.
The next question is, would these patients be better managed at an academic institution?
Well, that's a tough one. I think if the correct referral is made, so if the patient presents at primary clinic, a healthcare clinic, or secondary healthcare clinic, they should be referred to a tertiary clinic, yes. But if seen in private practice by a dentist, obviously the next line would be referral to a specialist, such as your oral medicine specialist, that is best suited to handle these types of situations. In cases where, we're dealing in South Africa with a low socioeconomic state of economy, we are dealing with a lot of the influx of patients that go to primary health sites and secondary health sites that kind of feed into that tertiary institution setup that we get. And a lot of these patients, although they may present with a 65% oral manifestation, a lot of them are seen at dermatology and then referred to us. So again, the tertiary institution is best, I would say, in terms of a referral basis when these are seen.
And also another important point is the fact that the medication that these patient needs, is supplied by the government, which is more difficult to sometimes get in private, surprisingly.
Yes, and more expensive as well.
Of course. Okay, another question. How often do you use methotrexate? So I think particularly in this case, I think let's focus there because this question needs to be patient specific. So how often do you use the methotrexate, and what side effects are there with the use of this drug?
So we don't use methotrexate often. If anything, we use prednisone. The methotrexate is usually prescribed by the dermatologist, and this is also because of the expense of the drug. It's a very expensive drug to administer, and so we generally, as oral medicine specialists, don't prescribe methotrexate. And just the follow-up to that, Sandra, was the side effects. So this is considered an immune or steroid-sparing drug. So the side effects of this aren't as adverse as one would see in a prednisone, because it's an adjunct to your prednisone. So they aren't as adverse or severe with regards to manifestation of side effects.
Yeah, and another thing I'd like to add with regards to side effects, in some patients, they actually mouth ulcers, okay, aphthous ulcers are actually a side effect. So sometimes you actually find the condition worsening before it gets better, but that just also ties in with the whole monitoring aspect of these complex cases. Okay, another question. Is recurrence common after successful treatment?
Yes, recurrence is common, as seen in this particular patient. Although they were recalcitrant, when the patient was placed on prednisone initially by dermatology, there was some sort of not remission or resolution, but there was a decrease in the number of ulcerations or any erosions that were present. But you can have recurrence of this. I'm not sure of the exact percentage. I would have to go look that up, but the recurrence is possible, and it does occur in instances where you also have triggering factors that haven't been identified. So if you have a triggering factor that hasn't been identified in these individuals, you can have a recurrence that occurs in these individuals. I'm not quite sure of the percentage. I'd have to check that for you. I think you're on mute, Dr. Koutras.
My apologies. I see there's a hand up in the chat room, Dr. Manenje. The platform is yours. Perhaps that was an error. Dr. Lalu, I see your hand is up. Please type the question in the chat box in the Q&A. The raised hand feature does not work. Okay, there's another question, Dr. Golele. Do you use indirect immunofluorescence for the diagnosis of Pemphigus vulgaris?
No, we don't use indirect immunofluorescence. We use direct immunofluorescence for the diagnosis of Pemphigus vulgaris.
So we don't use it at the institution. It is quite redundant. Yeah. But yes, by all means, we could use it, but it's with direct, we get exactly what we need.
Yeah, it's more specific and for the diagnosis of PV.
Anything else? I think we've gotten some nice questions. Perhaps the last opportunity to write something before we round up the session. Okay, Dr. Golele.
Thank you.
I think that's it. Thank you once again very much. I thoroughly enjoyed it, and I hope the rest of the colleagues did too. And hopefully they will all join next week. for the next registrar to present a different topic.
Thank you very much.